Today's topic is spectrum of fatty liver diseases. Our speaker is Dr. Rajni Yadav, Madam, Professor in Department of Pathology, AIIMS, New Delhi. Chairperson is Dr. Rahul Shah, Consultant Gastroenterologist, Critical Care, NRT Hospital, Mumbai. Today's moderators are myself, Dr. Aarti, Assistant Professor, NIMS, Jaipur, Dr. Leena Paul, Specialist Pathologist, Sareen Lan, Bahrain. Today's webinar host Dr. Anita Borges, Madam, Consultant Pathologist, Center for Pathology, Tata Trust, Mumbai, and Dr. Sumit Gujral, Sir, Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. There are few reminders, few disclaimers, few more disclaimers. So our next upcoming talks are slide seminar on approach to liver biopsy by the Dr. Siddharth Datta Gupta, sir, National Academic of Medical Sciences, Adjunct Professor, Department of Pathology, St. John's Medical College, Bangalore, on the 4th April. And on the 9th April, the topic will be chronic hepatitis and liver disease by Dr. Anjali Madam, Professor, Nayan Hospital, Mumbai. So let's start. Rajni Madam, over to you, ma'am. You can share yours.
Thank you, Aarti.
Aarti, you have to stop here.
Good evening, everyone. So I shall be talking today about the spectrum of fatty liver diseases. Since this is the first talk of the liver chapter, so let's once revise about the macroanatomy and the microanatomy of the liver. So this we all know that liver has two lobes, the right lobe and the left. Right is much greater than the left, and these are separated by the falciform ligament. So this falciform ligament, it actually attaches to the interior abdominal wall, and the base of this is the ligamentum teres. So if you see the posterior aspect of the liver, so here is the hilar area. So this area is very important as the inflow and the outflow is located here, and the gallbladder also rests in this fossa. So if we see the Quinault classification, so there are 8 liver segments. Now why these segments are important? So these different segments are independent functional units. Now they have their own portal pedicle. So that means the hepatic artery, the bile duct, the portal vein branch, and also the terminal hepatic vein branch. So that is there in each of this segment. So this is very important for the GI surgeon and for the anatomical resections. See, non-anatomical resections are taking some wedge portion of the liver out, and anatomical resections are based upon this segmental anatomy. So see the left lobe, it has 2, 3 and 4, 3 segments. So if you take out the 2 and 3, so that will be called as something like left lateral segmentectomy. And then you can have a left medial segmentectomy if you take out the segments 4. Then similarly, the right segment lobectomy. So either that can be anterior segmentectomy or the posterior. So when 2 segments each are taken out, or if you take these 4 segments out, so that will be called as right lobectomy. Similarly, if you take out 2, 3 and 4, so that becomes a left lobectomy. And see, similarly, it can be a right extended lobectomy when other than the right lobe, you take out this segment 4 also. Similarly, left extended when you take out this 2, 3, 4 and 5 and 8. So see, on the interior aspect, you can't see segment 1. So segment 1 is seen on the posterior aspect, which is known as the caudate lobe. And see, here we can see, so we have this portal vein, and then we have this celiac artery, and then so this vein is actually your terminal hepatic vein that drains into the inferior vena cava. So if we see the drainage, so basically the outflow is through the hepatic vein which drains into the inferior vena cava. And there are 3 hepatic veins. So one is the right hepatic vein, then is the middle hepatic vein, and then is the inferior hepatic vein. Now the middle hepatic vein that divides the liver, so it is in between the right and the left lobe. whereas the right hepatic vein is in between these anterior and the posterior segments. And then the left hepatic vein is between the medial and the lateral segments in the left lobe. And if you see the portal vein, that's the purple one, so that divides the upper and the lower segments. So now this is very important for the segmental resections. See, nowadays with the advancement in the imaging, so the smaller lesions are being detected. So that's why you want to carry out these resections, which are focusing on some segments only, and then you can retain the rest of the portion nicely, and the patient can have a better quality of life. Then if this is again highlighting the outflow, so I told you like right hepatic vein, middle and the left. So three hepatic veins, they join to form the common hepatic vein which drains into the eye. If we see the inflow of the blood, so the liver is an organ which has a dual blood supply. So the 80% of the blood supply is from the portal vein, whereas 20% of the blood supply is from the common hepatic artery. Now this portal vein, how does that form? The splenic vein and the superior mesenteric, which is coming from the intestine, so they combine to form the portal vein. Whereas the common hepatic artery, it's a branch of the celiac axis, and then it divides into the right and left hepatic artery, and those subsequently divide into the smaller branches inside the liver. So this is the dual kind of inflow, and this is the outflow of the liver. So liver is an organ which is actually richly vascularized, and this is very important even at the time of the transplant. Then if we go inside this, so that was the macroanatomy. So if we go inside and see, so we have this lobular model to understand the architecture of liver, and one is a SNR model. So if we see this lobular model, which is, it is composed of lobules, which are like hexagons. So if we look at one hexagon, so at the center, you will have a terminal hepatic vein or the central vein branch, whereas at the corners of this hexagon, there are portal areas. Now these portal tracts or the portal areas, they have three structures. So the portal vein, the arteriole, and the bile duct. So the hepatocytes, they are arranged in cords in between this central to portal area. Again, here we can see this is hexagon of the lobule of the liver, and then in the center you have central vein. So this is known as terminal hepatic vein or the central vein. And then at the corners you have these portal areas. Now see the blood supply. So near the portal area, so you have here the portal vein and the hepatic artery. So that means the hepatocytes which are near to the portal area, they will be richly vascularized or richly perfused. Whereas the hepatocytes which are most away from that, so which are near the central vein, so they have the least blood supply. Now the hepatocyte which are near the periportal, so that's the zone 1. The around the central vein, the hepatic zone, that is zone 3. And in between the 1/3 which is left, that is zone 2. So basically the blood flow is occurring from portal to the central, whereas the bile flows in the reverse direction from the central to the portal. A word about the fibrosis. So what happens actually in the liver? So see, the canaliculi, they are formed by the adjacent hepatocytes. So the basolateral surface that gets invaginated this membrane to form the canaliculus. So this is a, if you see, so this is a canaliculus. Then if we see this surface which is facing the sinusoids, so see, this is the sinusoidal space. Now the sinusoids, they are lined by this endothelium, and this is an incomplete endothelium or the fenestrated endothelium. In between this endothelium and the hepatocyte plate, there is this little space, this space. So this space is known as space of Disse. Now this space is normally, in the normal liver, you can't actually see this on microscopy. In this lies these quiescent stellate cells, so which are known as ito cells. And then the Kupffer cells are on the outer side, and the blood is actually flowing here in the sinusoidal space. Now what happens when there is an injury? Then your Kupffer cells, they are activated and their cytokines are released. And what happens then? This the stellate cells, they become activated and they get this myofibroblastic configuration. So here, so they have turned into myofibroblast, and then subsequently TGF beta is produced and the collagen is laid down in this space. So the fibrosis actually starts from this area. Now, fibrosis actually is very important from biopsy point of view. So, because half of the times the indication of the biopsy is assessment of the stage of the fibrosis, that how much fibrosis is there, so as to guide the treatment of the patient. Now, how do these people with liver diseases, non-neoplastic liver diseases, they land up to the clinician? So either they can have a fulminant or the acute liver failure kind of presentation, or they may have a chronic liver disease which was compensated for a long period of time, and then it becomes decompensated, and then they present with that at a later age. And then sometimes what happens, it is a incidental, so they are asymptomatic, they go for a screening test. So like nowadays most people, they will actually go for a routine LFT, liver function test, and then you find that the enzymes are abnormal. Now, what are the different kind of enzymes? So the liver function test which is commonly done will include a SGOT, SGPT, and the alkaline phosphatase and the bilirubin. Then if you see, and the serum albumin. So if there is a damage to the hepatocytes, then the SGOT, PT, the LDH will be. But if there is a damage to the membrane of the canaliculus, or there is a excretion problem, so then the bilirubin is going to be increased, and it may be increased in the serum, urine, and the bile acids may be increased, and then alkaline phosphatase and GGT are elevated. If the disease is persistent for a long time, then the hepatocyte synthetic function gets affected. So the serum albumin and the PT, they get altered. And in the acute liver failure, they may be hyperammonemia. So a careful evaluation of the liver function test and the biochemical parameters, so that tells you that what kind of damage is there in the liver, which actually tells you that whether you want to go for a biopsy or not. So if we go to the microscopy, so the histopathological assessment of liver biopsies for the non-neoplastic diseases. So at our center, so we do 4 stains. So by convention, so by default on every non-neoplastic case, we do this HNE, then pass with diastase, a reticulin stain, and a Mason's trichrome stain. So I'll show you that what are the advantages of these stains. Now that's the normal HNE. So once you look under the microscope, so normal liver is going to look like this. So that's the central vein. So it is lined by a flat endothelium. Now this is the portal area where you have the vein, arteriole, and the duct. So this is the zone 3, and this is zone 1 near the portal, and in between you have the zone 2. So see the hepatocyte cords, they are actually arranged in a single or a double plate thickness, and mostly they are not straight cords, so they are zigzag. So that's the normal pattern of arrangement of the hepatocytes in zigzag cords from the central to the portal area. Now that's again a central vein, so we can identify and see, so that it is one of the vein which has little a cuff around it, so it has some thickness as compared to the other veins in the body. So, and then hepatocyte cords, they look normal. Again at the higher part, so we can see this endothelium, so that's the central vein. Then this is the reticulin stain. Now if you see this reticulin stain, so again this is highlighting there, here is the central vein, and see these hepatic cords. So see there is a reticulin framework. So see the cords, they are not stained, and these cords are being supported with this reticulin fibers. So these are the reticulin fibers. So it is forming a meshwork. So this is actually holding everything in a correct manner. So if there is a problem in this, so in actually acute and chronic diseases both, so reticulin framework will be altered. So you will have the condensation of the fibers. So this is the normal reticulin framework. So when the fibers, they are not parallel to each other, so they are around the cords of the hepatocytes. And if you can actually appreciate the thickness also, so mostly here we have got the 1 cell plate thickness of the hepatocytes. Now this is a Mason's trichrome. So it is used for again assessing the collagen fibrosis. So now the hepatocytes, they are stained red, and whatever fibrosis will be there will be stained blue. Now this is a central vein, so that's normal. So that's the wall of the central vein, but there is no fibrosis here. Now that's the portal area. So if you see this area, so here we have got these veins. So veins, they have generally bigger lumen and the thinner wall. Now that's the duct. So it has a cuboidal lining and the lumina. So this is the cuboidal lining. And then here you have got a small arteriole. So the arteriole will be small and the wall will be little thicker than the vein. Now, if you see, so you here there is this connective tissue in the portal area. You have some lymphocytes, and if you notice about this plate, so these hepatocytes which are immediately in the vicinity of this portal area, so that's the limiting plate. Now, this limiting plate of the hepatocytes is very important. So, interphase hepatitis is when this limiting plate is damaged by the inflammatory cells. So, normally, see the inflammatory cells are there in the portal area. Once they enter and they destroy this row of the hepatocytes, that is known as interphase hepatitis or the limiting plate necrosis. In the older times, it was called as limiting plate necrosis. At the higher, these are two ducts. This is vein, this is again vein, this is a small arteriole, and that's our limiting plate. Now that's the reticulin stain. Again we can see, so that's our portal area. Now see the shape of this portal area. So in the biopsy, you will have mostly smaller portal areas, but it depends upon which site is being, so the biopsy is taken from which site. So you may have smaller, intermediate size or the bigger portal areas also. And the size of the structures in the, as the size of portal area increases, the size of these structures, the artery, the vein, the duct, that will also increase and the connective tissue will also increase. Now this is an empty stain. Again, see it is highlighting the portal area. This is one of the portal area. This is another portal area. So here we can see the duct, the vein and the arteriole. And see, so the contours are fine. So that means there is no fibrosis. You don't have this irregular kind of bands of fibrosis. This is a higher part of the portal area. So see, duct is nicely visible here. This is also a duct. This is arteriole and this is vein. Now, if we come to the lobule, so we saw the central vein, we saw the portal areas. So in between you have these hepatocytes. So these are the hepatocyte cords. And if we look at the hepatocytes, so these are round to polygonal cells. They have this abundant paleosinophilic cytoplasm and round nuclei. Now see the binucleation, so little binucleation, nuclear enlargement or tiny nucleoli. These are normal features for liver because it is an organ which is constantly regenerating. So these are normal findings in any liver biopsy. Then in between these are the sinusoids where the blood circulates. And see, this is the endothelial lining. So that's a fenestrated endothelium. And see now between the endothelium and the plate, we don't have any gap. So because that's a normal biopsy. So sometimes, so once this is actually this gap is increased, then you can see that space of Disse. And then in the normal liver biopsy also the Kupffer cells and the I2 cells are not prominent. So like here we can feel that this may be I2 cell, but unless it is pathological, so there is an injury, so these cells are not very prominent. Then this is a stain which is passed with diastase. So normally liver has abundant glycogen. So this is with diastase, so the glycogen is digested. So that's the central vein. And these are the bland hepatocyte cords which are visible. So see, if you do a pass, what will happen? So liver is an organ which is rich in glycogen. So a normal biopsy, so that will also be full of glycogen. So the diagnosis of glycogen storage disease cannot be made by use of this pass and pass with diastase. Since the normal hepatocytes, they are full of glycogen, and once you treat it with diastase, so see all the glycogen has disappeared. Now that's the lobule in the Mason's trichrome stain. So see, normally you don't have any blue color. So these are the red cords of the hepatocytes and they're lined by the endothelium, but you don't have any fibrosis. So the spatial stains I was telling you about, so the reticulin. So how does reticulin help? See, so now the condensation of the fibers will happen in the acute changes also, and the chronic also. So if there is a acute failure and there is a necrosis of a patch of hepatocytes, then also your fibers can be condensed, and when there is fibrosis, then also. So to differentiate acute versus chronic, so you will need a Mason's trichrome or the hematoxylin von Giesen or a serious red. So these three stains, they are used for type 1 collagen. So they will tell you that how much is the true fibrosis. Then there PAS, I told you, so PAS and PAS with diastase can be used. So PAS will stain the glycogen, but PAS positive diastase resistant material is important to identify. So in alpha 1 antitrypsin deficiency, you see inclusions which are PAS positive and diastase resistant. So that's why you want a PAS with diastase in the liver biopsies. Then if you have some hemosiderin deposition, you can do a Pearl's Prussian blue stain. Then for the copper, you may do a rhodanine stain. Also, Orsin stain can be done for the copper associated protein. So this is important for Wilson's and the cholestatic diseases. Then Orsin has additional advantages. So like reticulin, it stains so elastic fibers. So you can actually differentiate necrosis and collapse versus fibrosis with the Orsin stain. So if you are confused that whether acute versus a subacute failure, so or a chronic disease, so you can use this Orsin stain. Then it also highlights the ground glass inclusions of the hepatitis B virus. So these are the spatial stains which you can use in the liver. Then today's talk is mainly focused on the steatotic pattern. However, I'll just briefly touch upon the terminologies of the hepatic injury, which we will be seeing. So with the different cases, I will again tell, but just some general. So what is like ballooning degeneration? Now, ballooning degeneration is the swelling of the hepatocytes. When they become swollen, and they lose their normal contours and their cytoplasm becomes very clear, so wispy clear cytoplasm, so that is known as ballooning degeneration. Then apoptotic body, so like at other sites, so it's a apoptosis, so it's a shrunken pink cell which is also known as acidophil body or the Conselman body. Then the cholestasis may be seen actually in the canaliculi. It may be seen in the form of feathery degeneration in the hepatocytes, or it may be seen in the ductal system. Then Mallory-Denk body. These are inclusions which are formed from the cytokeratin filaments, and they are generally present in the ballooned cells, and they are very coarse pink ropey structures. So these I will show you. Then what is satellitosis? If the neutrophils, they accumulate or they arrange, they accumulate around the degenerating cells, ballooned cells. So that is known as neutrophil satellitosis. So arranging around that. Then steatosis, that is greater than 5% is pathological. And then the steatosis can be either macrovesicular steatosis or microvesicular steatosis. Now, the macrovesicular steatosis, that means a large vacuole. That means you can easily see and draw a line around that. Now, microvesicular steatosis is so small vacuoles that you may not be able to identify those vacuoles. So that cell may look like ballooning degeneration. Now, this macrovesicular steatosis is further divided into small droplet and the large droplet. If there is a large droplet fat, so that is large droplet macro, or that displaces the nucleus. There may be a small droplet macrovesicular which may not displace the nucleus. Then interface hepatitis, I told you, so the limiting plate damage, so that is the interface hepatitis. Then if there is a reduction in the ducts, you can't see, so that's ductopenia. So that is commonly seen in the ductal diseases like primary biliary cholangitis and the primary sclerosing cholangitis, or the vanishing bile duct syndrome, or in children it may be inherited as a part of Alagille syndrome. And then the onion skin fibrosis, that is again one peculiar feature. So that's a concentric fibrosis around the bile duct, and it is seen in the primary sclerosing cholangitis. So in the next talks in the liver chapter, like you'll have the hepatitic talk and the liver biopsy. So you'll cover the other features other than the steatotic. So let's have a question. So can you identify this stain? So this is an image from a liver biopsy, and this is a stain. So the options are Orsin, rhodanine, Mason Fontana, and the Persian blue. All of you can vote for the options.
Yeah. Many are replying. The majority is saying option D, Russian blue. But
Yeah,
there's
so
one
that's
wrong
the
one.
Persian blue. So very good. So
Okay.
that's the Persian blue stain, pearl stain, and it is highlighting the hemosiderin. So see, hemosiderin deposition can be there inside the hepatocytes. It can be there inside the Kupffer cells. So it can be there inside the portal macrophages. So once there is hemosiderin deposition, you should actually try to make out where it is deposited, what is the amount. Again, is it leading to fibrosis? So iron grading has to be done on those biopsies. So mostly, the inherited ones, they are less common in our country, the hemosidrosis. So mostly the biopsies which you will get with lot of hemosiderin, they will be secondary hemosidrosis. So like with the hematological disorders, hemolytic anemias, like the most common is thalassemia. So we tend to get a lot of biopsies for that, because slowly as it is getting deposited, it may lead to fibrosis. And before sending the patient for a bone marrow transplant, you want to look that how much fibrosis has occurred in the liver. So if it is too much of fibrosis, then the bone marrow transplantation may not be that advisable. So that's a Persian blue stain. So after finishing the normal, so let's go through the cases of the steatotic pattern. So that's the first case. Now here we can see there are multiple liver biopsy tissue cores, and at this part, so this is the 4x. So at this part, we predominantly we have got a steatotic pattern. So these are lot of vacuoles which are covering actually majority of the portion of this biopsy. So at the higher part, once you see this predominant steatotic pattern, the next thing you will do is that, so you try to identify what is the amount and is there a zonal distribution. So see, this is the portal area. Again, this is the portal area. So the steatosis is sparing some portion near the portal areas. That means it is actually filling up the zone 3 and the zone 2, and it is reaching the zone 1. Then the next thing is to look for the associated features. So what else other than the steatosis can we see? If we see the portal areas, the inflammation is not that much. So if the inflammation in the portal area is not much, so that means we think that it is not a viral hepatitis or autoimmune. So hepatitic patterns, they mostly have inflammation dominating over the portal area. So this is a disease which is focusing on the lobule, and it is more steatotic, and it is based upon zone 3 and zone 2. So at the higher part, we can see again, so macrovesicular steatosis, see the vacuole is so big that it is displacing the nucleus to the periphery. So that's mostly a large droplet macrovesicular steatosis. And see, other than that, what else we can see? So these are ballooned hepatocytes. These are swollen. See, their cytoplasm is degenerated. It has become clear. And then what is all this? So this is inflammation which is there in the lobule. So you have got a steatohepatitis. See, only fat, so that will be steatosis. Now steatohepatitis, because we have got proper lobular inflammation in association with the fat. So here we have got a disease which has a zone 3 pattern, which is predominantly having steatosis. Along with that, we have ballooned hepatocytes and significant lobular inflammation. Again, at the higher part, you can see all these ballooned hepatocytes beautifully at this part. So these are ballooned. And see, inside this ballooned hepatocyte, this kind of pink aggregate. So this is a ill-formed Mallory hyaline body. And if you look at this inflammation, so it is mostly having the lymphocytes and the histiocytes. So this is the classical picture of a non-alcoholic fatty liver disease. So what else you can see? So you can have this large droplet, you can have this small droplet fat. Then you can have these glycogenized nuclei, the clear nuclei. So these are seen with the metabolic syndrome, with the diabetes, with the non-alcoholic fatty liver disease. Then you tend to have this inflammation, and in NAFLD the inflammation mostly consists of lymphocytes and these steroid laden macrophages. What is steroid? So that's a form of lipofuscin. So mostly you have macrophages which have steroid, and that tells you that there is a acute wear and tear. So it's a sign of wear and tear and the repair. Then here this inflammation is actually aggregating and forming a tiny granuloma with a fat vacuole. So this is known as lipogranuloma. So these features are classical for non-alcoholic fatty liver disease. Then if we see the past with D stain in this case, so see this pink material, so this is spheroid. So spheroid laden macrophages, they are highlighted with the past with diastase. And then in the reticulin, see this is the portal area, there is some sparing around that. Then this is our fat, and it actually disturbs the reticulin framework little. So we have to see in the empty stain that how much is the fibrosis. So one non-alcoholic fatty liver disease, though what is the next step? So the clinician wants a scoring. So one is the scoring, which is a grading. So the three features, the steatosis, the ballooning, and the lobular inflammation, they have to be graded. So if the fat is less than 5%, so that's non-pathological. So up to 33, that is 1/3. So this is of the total biopsy area. So total biopsy area, you take it like 100. And then that you see, so if it is involving 1/3 portion, so that's score 1. If it is involving 2/3, so it's like 2. If more than that, it becomes 3. Then if you see few ballooned hepatocytes, it is 1. And then if you see many ballooned hepatocytes, it's 2. Then this lobular inflammation has to be scored. So just pay attention that it is lobular inflammation, not the portal. So in the NAFLD, the portal inflammation is not at all given a scoring. Lobular inflammation has to be counted in a 20x field. So it can be either 1, 2, or 3. So once you add the score of these three, so you will get this total score. So there are multiple scoring systems, but this is the most widely practiced and applicable scoring system, which is the NASH CRN, NAFLD activity scoring. So the minimum score is 0 and the maximum is 8. So these are the examples. So see no fat, so that's S0. Now you have like 1/3 fat, that is S1. So if you have 2/3 fat, so that's S2. And this is having more than 2/3. So see the uninvolved are lesser. So it's 2/3, say more than 2/3. So it's S3. Then here we can see these ballooned hepatocytes, they are less. But here if we see, so most of the hepatocytes, they are ballooned. So it is B2. Then the lobular inflammation, here it is scant lobular inflammation. So it has mainly steatosis and ballooning. Here you have some foci, more than that. So that is L2. And here see you have several foci. So that's how you will grade your biopsy of the NAFLD. Then after the grading, the fibrosis assessment has to be done. So see, NAFLD is a zone 3 disease. So fibrosis starts from there only. So you'll have a mild perisinusoidal fibrosis in the stage 1A, which is the earliest. So this is difficult to identify on HE. So you need a Mason's trichrome for that. Once it increases and becomes little thicker, so that is 1B. If the fibrosis is only in the porta, that's 1C. But if you have a combined lobular and the portal fibrosis, the stage becomes 2. Then if you have a bridging septa. So what is bridging? Now bridging is a fibrous septa. That means it is a connection. It can be in between one portal area to another portal area. It can be from one zone 3 area to another zone 3, or it can be from a zone 3 area to portal area. So there can be different patterns of bridging fibrosis, but once you see bridge, so that becomes stage 3, which is very significant. So the irreversibility starts from here. Though nowadays, yes, we know that the bridging fibrosis and even the cirrhosis are partly reversible, but still it is a significant fibrosis stage. Then once you see the nodule, so that's the stage 4. So these are the examples. So like in this case, see, this is the central vein and there is this minimal blue strands which are going out from the vein along the sinusoids. So that's the very delicate and the earliest stage of fibrosis 1A. Now see, that's the portal area and that looks fine. Now in this case, if we see, so we have this, the fibrosis has become more thick, but it is again creeping along the sinusoids in between the steatotic hepatocytes. So that is 1B. Then here we have got this portal fibrosis only. So that's 1C. Now in here we can see that we have this perisinusoidal fibrosis. Also we have some portal fibrosis. So that becomes a stage 2 fibrosis. Here we can see that we have got these bridges or the septa. So see, they are connecting one area to another. So these kind of septa formation, so that is a bridging fibrosis. So that means the stage 3. Then once you get more and more bridges, ultimately you'll get these incomplete and the complete nodules. So because the biopsies are like true cut biopsies, so you may not see the complete nodule because the thickness of the cores is not that much. So the nodules, if they are big, so you may not see complete nodule. Once you see incomplete nodule, so that's also cirrhosis. So in the NAFLD, if we want to conclude, so what is the use of the biopsy? So yes, confirmation of the diagnosis. You have to do an activity score and the fibrosis stage assessment, which can be correlated with the non-invasive investigations we have now. Then to rule out the differential diagnosis and the coexisting diseases, because most of the people will just present with the elevation of the OTPT, and then you have differentials of autoimmune hepatitis and the non-alcoholic fatty liver disease. Then if the patients have to be taken in the trials or they are undergoing a therapeutic intervention like bariatric surgery, so pre and post therapy, you can actually compare the scoring in the biopsies. So they are important for that also. So let's take another question. So in this image, which of the following feature other than the macrovesicular steatosis, see, you can see a lot of steatosis. So other than steatosis, which other feature is prominent in this image? The choices are ballooning degeneration, lobular inflammation, nuclear glycogenization, or cholestasis.
The maximum response is for C, nuclear glycogenization.
So that means everybody is very attentive. So yes, so it is beautifully highlighting this nuclear glycogenization. See, this glycogenization or the inclusions. So recently there have been a lot of studies into this, and it has been seen that these are also of two types. Type 1 glycogenized or inclusions, or type 2. Now what is difference between this type 1 and type 2 is that this type 1 are surrounded by a membrane, whereas the type 2 either it involves the whole nucleus or it doesn't have this surrounding basophilic membrane. And on PAS stain, actually, so they stain positive and it is digested with the PAS with diastase. So that means yes, they are glycogenized. So here we can see, so once the studies were conducted, so it was found that these type 1, which are surrounded with a membrane, they have more of this autophagy associated proteins and the degenerated organelles. See this ubiquitin P62, cathepsins, and the lysosomes and the degenerated organelles. And it was seen that these are actually bad prognostic factors. So both of them, they can be found in NAFLD, and they increase with the increasing severity of the disease. However, the type 1 are playing an important role in the disease progression. So you people can actually, so that's a nice article. So you can go through this article. So it's a lot of work was done on basis of which these conclusions were taken out. So going to the next case. So here we have got again a liver biopsy which shows some amount of macrovesicular steatosis. But what are the differences as compared to the previous case? Now here we can see, yes, we have a distorted architecture. So we have these nodules. and in between the nodules, so we have these fibrous septae. So these nodules are surrounded by fibrous septae. If we see these septae, so these have this blue area, so these are all, this is inflammation. And see these ducts, so there is a ductal and ductular proliferation. So it's a cirrhosis and it has inflammation, prominent ductal proliferation. And if we see the lobule, so we can't see normal hepatocytes at all, so they are mostly degenerating. And this disease is actually affecting both the portal areas and the lobules as compared to the previous. So in the previous, the main disease was confined to the lobule and the portal areas were hardly affected. Now let's going at the higher part. So these are the portal areas and the fibrous septae. So see these ductal structures. So ducts are actually damaged. That's why there is a ductal and ductular proliferation. So if you see this kind of structure which doesn't have a lumen, you will call it a ductule. If it has a lumen, so you will call it a duct. So whenever there is an injury, then there is a proliferation. And you see this neutrophils, even they are forming this debris inside the lumen of the duct and they are affecting the lining of the duct. So there is a inflammation which is rich in polymorphs and it is affecting the ducts. So the neutrophils, when they affect the duct, you call it a cholangitis. Then other than lymphocytes and neutrophils, you have histiocytes. Then you have this abundant pale fibrosis also. If we look at the lobule, so see, we have again fibrosis here and see none of the normal hepatocytes are visible. So you either have these steatotic vacuoles or you have this pink pores deposits. So these are the Mallory-Denk bodies. So this is abundant pores, ropey Mallory-Denk deposition. It is too abundant. So see all the hepatocytes, they are full of these pink structures. And then they are swollen. And then the similar inflammation rich in polymorphs and histiocytes, lymphocytes, so it is affecting the lobule also. And this fibrosis is creeping in between the hepatocytes. Now this is a classical picture which you will see in a alcoholic steatohepatitis. At the higher part, so you can see your steatotic pattern, and then these are the, see, Mallory-Denk bodies. All these are so Mallory-Denk bodies. The whole field is full of that. And see what is happening. So here you can see some pigment also. So basically there is some cholestasis also in the hepatocytes that is giving this granular appearance. And then these are actually the cytoplasm is getting degenerated. And see these neutrophils. So these neutrophils, they are surrounding these ballooned cells which are containing the Mallory. That is known as neutrophil satellitosis. And once this extensive damage happens, the rest of the hepatocytes, they try to regenerate. So you may have this nucleomegaly, prominence of nucleoli, and some pinkish cytoplasm because of the regenerative change. Then if we see here, so there is this red structure. So this is bigger than RBC and it has color of that. So this is a mega mitochondria. So this is seen in alcoholic liver disease. And it is a bad prognostic feature if you see the presence of mega mitochondria. Here in this image, we can see lot of fibrosis, and it is so creepy, lamellar fibrosis, which is just eating up the hepatocytes. So hepatocytes, see, they are getting ballooned. They have so much of Mallory. Their cytoplasm has degenerated. So Mallory forms from the intermediate filaments. And then they have this bile stasis. Then the inflammatory cells are actually destroying them. And then the fibrosis is also eating up the hepatocytes. So your hepatocyte volume or the bulk is going off. Then in alcoholics, in addition, see, you get this cholestasis. So inside the hepatocytes, we had the fatty degeneration once they have this bile stasis related ballooning. And then this is canalicular cholestasis. So alcoholic liver disease, either it can show you a steatotic pattern like NAFLD, it may have a cholestatic pattern, it may have a combination of both. But if you have steatotic plus cholestatic with abundant Mallory, this kind of pericellular fibrosis, neutrophil satellitosis, so that's a classical appearance. So, but you may not get all these features in every case. Then if we see in the empty, so we can see these are the nodules. And see in between also there is fibrosis. So this is the chicken wire fibrosis which is in between the hepatocytes. And see what is the advantage of empty? It beautifully highlights your Mallory-Denk bodies also. So they are stained blue whereas normally the hepatocytes, they will be red. So the Mallory-Denk bodies are blue. Now, because these are the intermediate filaments, CK818 IHC can be used to highlight these. So they combine this intermediate filaments and the heat shock proteins, they combine to form these bodies. This is another pattern which can be seen in alcoholic liver disease. This is known as acute alcoholic foamy degeneration. Now see what is happening here. All the hepatocytes, they are swollen, and they have these tiny vacuoles which you cannot draw a line around. So that's a microvesicular steatosis which is diffuse. Now this pattern is either seen in this alcoholic injury, which is actually very bad, and it indicates mitochondrial dysfunction. Then this may be seen with the toxin injury, like this drug-induced toxicity, valproate, you can see this injury, doxycycline, and also with the Reye syndrome, you can have this picture. So alcoholic liver disease can have different kind of morphological patterns in different patients. No, actually what happens in alcoholic liver disease with the continuous abuse, so either you have a steatotic or you may have a hepatitic, but if it is continued, so eventually it leads to cirrhosis, and subsequently you may develop, so the patients may develop a hepatocellular carcinoma also. Whereas in non-alcoholic fatty liver disease, what is occurring? So most of the patients will have a isolated steatosis. See, less number of patients, they have proper steatohepatitis. So once the inflammation combines with the steatosis, then only these people, they progress to advanced fibrosis or the cirrhosis. So that's the difference. So in the alcoholic, you have lot of inflammation, so the progression to the cirrhosis is very high. Now, the steatotic liver disease nomenclature has been recently changed. So that is very important for the postgraduates to know. So earlier, so what was called as NAFLD is now being called as MASLD. That is metabolic dysfunction associated steatotic liver disease. So why this change of nomenclature? See, earlier the name was non-alcoholic. That means there is no alcohol. So that means you are actually putting the name of another etiology in this disease. So now this appears more correct. So it is metabolic dysfunction associated or caused steatotic liver disease. So for this, so patient needs to have steatosis and at least one of the 5 cardiometabolic risk factors, which are impaired fasting glucose, obesity, then the elevated triglyceride, low HDL cholesterol, or a impaired, raised blood pressure. So any of the risk factor plus steatosis, so that becomes a metabolic dysfunction associated steatotic liver disease. Now that just has steatosis. But if you have again steatohepatitis, so you will call it as MASH, metabolic dysfunction associated steatohepatitis. So NAFLD has been replaced by MASLD, NASH has been replaced by MASH. Then there are some people who actually have some features of both. So those who actually fit into MASLD, but they are consuming alcohol, which is not in the range of the alcoholic liver disease, but it is actually significant. So if they consume alcohol and they have features of MASLD, so that's a combination. So you will call this MET-ALD. So that means metabolic dysfunction associated and with significant alcohol intake also. Then in the cases in which there is no metabolic derangement, no alcohol history, you don't know, so you can call that as a cryptogenic steatotic liver disease. So let's see another question. Which of the following diseases show presence of Mallory-Denk bodies? Alcoholic liver disease, primary biliary cholangitis, Wilson's, or all of the above?
Most of them have replied all of the above, but there are few option A also, alcoholic liver disease.
Yeah, so actually all these diseases can show. So the difference is that this alcoholic liver diseases, it generally shows abundant Mallory-Denk bodies. Then whereas this primary biliary cholangitis, Wilson's, and there are many other diseases also. So they tend to show focal Mallory-Denk bodies, which are mostly periportal or periseptal. So that's the difference. So that's why in the non-neoplastic liver biopsy interpretation, you have to pay importance to each of the feature. You have to semi-quantitate that feature. So you have to see in which zone it is present, in which amount it is present. So that all is important for each of the feature. So how did this name actually came into being? So these were two different gentlemen. So one was Frank Bird Mallory, who actually discovered these bodies in the patients of alcoholic hepatitis. Whereas this Helmut Denk, he developed an animal model for these Mallory bodies. So later that was combined. So these bodies were subsequently called as Mallory Denk bodies. So is fatty liver disease all about non-alcoholic and alcoholic fatty liver, or there is more to it? So yes, there are other causes. So the non-alcoholic and the alcoholic, they're the chief prototypes of the steatotic liver disease, but you do have several other causes. So like viral hepatitis. So nowadays we don't get biopsies from viral hepatitis patients, but the steatosis may be seen in patients of hepatitis B and C, and especially with hepatitis C. So you have to be aware of that. So the viral type, they have replaced the biopsy totally, and you can assess the fibrosis also with the fibroscan. So you need to actually have those details. So like in our center, so in each patient, so we'll have all the viral serology, the autoimmune serology. So you have to carefully look at the clinical picture and all the investigations. So there is a long investigation workup for the non-neoplastic liver diseases. So that's essential before you actually release your report. Then another chief cause which is coming up nowadays is a drug-induced fatty liver disease. So see, variety of the drugs. So there is a long list, much more than this, which can induce a fatty liver disease. And these drugs are in common usage. See, tamoxifen, methotrexate. So the people who are being treated for dermatological diseases, the rheumatological diseases, so many autoimmune diseases, all of them, most of them, they can actually lead to a fatty liver disease. So this is a very important cause, and the clue for actually clinching this is the history. So a careful history taking from the patient is important to actually, because drug induced fatty liver disease may mimic any morphology. So it may have a steatotic pattern, and then it may have a polystatic pattern, it may have a ischemic pattern. So there can be different patterns of the drug induced liver injury. So there is like entire different spectrum, a whole class can be taken on the drug induced liver disease patterns. So see, one of the example you can see here is like this is a NAFLD like pattern which is produced by methotrexate, whereas here we can see lot of Mallory hyline. So that's an amiodarone induced injury which is looking like alcoholic. So there can be different patterns with the drugs. Then if we go to the uncommon causes, so which are not predominantly causing steatosis but can induce. So see, in the pregnancy, the fatty liver of pregnancy and the HELP syndrome, then the PCOD, which is quite common, hypothyroid. So these endocrine disorders, they can produce steatosis in the liver. Then not even overnutrition, so malnutrition, the total parenteral nutrition, then small intestinal bowel diseases, and the short gut syndrome, all that can also lead to a steatotic liver, even the acute weight loss. Then the toxins which are there nowadays in every other food item. So these toxins, they are coming up as a major cause of the liver injury, and especially the steatotic pattern. Then in adults, the genetic causes are quite uncommon. One is just hemochromatosis. But if you see the children, so in the children, the genetic causes are a dominant cause rather than the lifestyle related diseases. So if you see a steatotic pattern in a child, so the inherited causes have to be thought of. So let's go through the interesting case gallery quickly. So these are different cases which I encountered in my routine reporting. So in this C, we can see a nodule formation here, and the fibrous septa, they have lot of inflammation. So it is a dense inflammation. So it's a hepatitic pattern. Then these ducts are injured, and see they are proliferating. You can see, so there is a ductular proliferation. Now, if we look at the interface, so see the inflammation is damaging the limiting plate, and there is this SNR transformation. See this floral or the rosette formation of the hepatocytes. So when they are injured, they try to form this rosette kind of structures, which may have lumen or may not have lumen. So this is SNR transformation. And then the hepatocytes, they are swollen. So you have this nuclear glycogenization, you have some fat vacuoles, and then you have these lot of plasma cells. So that's a autoimmune hepatitis which has some amount of steatosis. So autoimmune hepatitis nowadays is one of the most common indication of the liver biopsy at our institute. And then the combinations of NAFLD with autoimmune hepatitis are also very high. Then the people who are treated with steroids, they can also have steatosis because of the treatment with steroids. Then this is another case. Again, we have a cirrhotic liver and we have lot of fat in the lobule. But if we look at the septa, so yes, again we have lot of inflammation. Ducts are injured and see they are proliferating. If we look at the lobule, we have more of non-alcoholic fatty liver disease kind of changes. And if we see at the periphery, so we have SNR transformation, we have plasma cells. So this had a combination of non-alcoholic fatty liver disease and autoimmune hepatitis. And this was a SLE patient. And this patient actually presented with progressive multifocal leukoencephalopathy to the neurology department. So see how diverse the presentations can be. So this biopsy we had got from neurology. This so here what we can see, there is yes some macrovesicular steatosis and there is this lot of inflammation also. So this pattern is a combined hepatitic and the steatotic pattern. And see what we have got. So we have got multiple granulomas. These are well circumscribed and they are non-necrotizing. These are in the portal area. Then here we can see the ballooned hepatocytes. So you have this lobular inflammation. So you have got some NAFLD-like changes, then spheroid-laden macrophages, the granulomas here, lot of interphase and the plasma cells. So basically you have got hepatitic pattern with granulomas and you have got some NAFLD-like changes also. If we look at the fibrosis, so see you have got portal fibrosis, you have also got this perisinusoidal fibrosis and it is bridging. So this is a case of sarcoidosis with a coexisting non-alcoholic fatty liver disease. Then next case, so again here we have got lot of fat. However, we have again got granulomas. Now these granulomas are bigger and then some of the granulomas show necrosis. Again in the portal areas we have inflammation, we have these ducts which are injured, they are proliferating. And see here we have got these ballooned hepatocytes. One patch of the biopsy is so different from the other. And these are completely swollen and pale. Then the fibrosis is in the portal areas and it is bridging from one portal area to another. And there is some perisinusoidal fibrosis also. So this was a case of tuberculosis with non-alcoholic fatty liver disease. See, so all people will not be obese with the non-alcoholic fatty liver disease. So you may have NAFLD in lean patients. So there is a lean kind of NAFLD also. This is another case. Here we have got nodule. So nodules are surrounded by the fibrous septa. And here if we see, so this patch is completely necrotic. So what has happened in this? So this patient had chronic liver disease. On the top of that, he has got an acute failure. So this is the acute upon chronic liver failure. So the etiology for this chronic liver disease looks hepatitic because there is this inflammation here. And this is your terminal heart failure related hemorrhagic necrosis, which is predominant in the zone 3. So see here also you can see, so these are the nodules. So this was a cirrhotic liver. Already the patient had CLD. And see, these are the ducts. In the ducts you have bile plugs and here you have zone 3 hemorrhagic necrosis. Then these necrosed areas, they are replaced by spheroid-laden macrophages. So basically you have got a acute upon chronic liver failure. So hepatitic was the chronic liver disease etiology, whereas heart failure and sepsis are the acute events. So these kind of biopsies also we tend to get a lot. So you have to actually see that what is the etiology for the acute thing and what is the etiology for the chronic thing. So you may have biopsies from ALF patients which go for transplant. You may have subacute liver failure. You may have chronic liver disease or you may have acute on chronic liver failure. Now this is another interesting case. So we have got lot of vacuoles here and the ballooned hepatocytes. So is there anything particular which is striking to you people? So here we have got these portal areas, some inflammation, some ductal proliferation. And see, other than hepatocytes, there are macrophages in the sinusoids, which are actually stuffed with something. So these are looking like tiny organisms, and with the pus and the SM, so these are staining as small dots surrounded by a vacuole. So that's histoplasmosis, which was disseminated, and see, it was producing a steato and ballooning kind of a pattern on biopsy. So just seeing the vacuole you should not stop there. So you have to look for each and every feature in the biopsy and make a diagnosis. Otherwise, you are going to miss the etiology. Now the pediatric world. So that's a different scenario. So why that's different? See, if we talk about the NAFLD. So in children, the NAFLD is exactly opposite to adults. So in adults, the disease is zone 3 based, whereas in the children, it is zone 1. So zone 1 is affected. So you have the steatosis, inflammation, fibrosis, everything in the periportal area. And the ballooning is more uncommon. Now see, in the children, the NAFLD actually occurs more after 10 years, so at least after 5 years. So in less than 5 years of age, so we should not suspect non-alcoholic fatty liver disease. So see here, there is a portal area, and you can see the fat is localized around the portal area. So that's a pediatric NAFLD pattern, and the fibrosis is also occurring in the portal area. But see, these children, once they grow older, they can have adult kind of NAFLD pattern also. So they can have either pediatric NAFLD or they can have that adult type NAFLD. Now this is another case, a child, so 5 years old child, and we can see, so predominant steatosis in the biopsy. And see, the empty stain is highlighting that it is progressing fast. So you have got this incomplete nodule, lot of bridging fibrosis and incomplete nodule in such a small child with diffuse macrovesicular steatosis. So if we do the pass, so it is highlighting just the non-steatotic hepatocytes and it's all digested. So the stain has not helped us. So what has he got? So in such a case, so you should suspect a inherited genetic or metabolic liver disease. So if in a very less age, you are having a steatotic pattern, that tells you that yes, the patient is likely to have a inherited genetic or a metabolic liver disease. Another case, this is also a child. Again, you have got these steatotic hepatocytes. But see, other than the steatotic hepatocytes, just look at these. So these hepatocytes, the cytoplasm is diffusely granular and it is looking like a finely ground glass. So that's the ground glass hepatocytes. And see, this empty is beautifully highlighting these ground glass hepatocytes. So though ground glass hepatocytes can be seen in the viral infection, they can be seen in many other things. So this is a child, and see, PAS is beautifully highlighting these ground glass hepatocytes. However, PAS with diastase tells you that it's all digested. Now that is a case of glycogen storage disease. So the type 4 glycogen storage shows the fat and the ground glass hepatocytes. Again, that's an inherited disease. This is again another child. So here we have got these vacuoles, and then here we have these ballooned hepatocytes, and there is, see, this pigment also. So it is cholestasis. Then we have got extramedullary hematopoiesis, and see, there is too much of this SNR formation. So the cells, they are actually fusing with one another. They are trying to form rosettes and giant cells. So it's a mixed steatotic and cholestatic pattern with EMH. And see, the fibrosis is not that much. So this was also a small child. And on the biopsy, so we could not clinch the diagnosis. So in children, yes, an important pillar for the diagnosis is exome sequencing. So the blood sample was sent for sequencing, and so he was detected to have this ARC syndrome. So in this, so actually he had a renal dysfunction. So this is a syndrome, so which has, so it is a cause of cholestasis, and these patients tend to have renal dysfunction and arthrogryposis, so joint abnormalities. So that is very important to clinch, see, because then only you can actually guide the treatment. Then this is another case. This is also a child. So here is the liver biopsy. So other than steatosis, what we can see here is, so these nuclei, they are enlarged and they have these eosinophilic inclusions. This is the kidney biopsy. Again, big pink eosinophilic inclusions in the nucleus. This is the lung biopsy. Again, the inclusion. And see, these are beautifully highlighted with the CMV IHC. So that's a disseminated CMV infection. So this patient actually, he expired. So these are the post-mortem biopsies from the different organs since he had a fulminant and disseminated infection. Now in children, and also in the adults, so Wilson's disease can present with a steatotic pattern, and alpha-1 antitrypsin and the lysosomal acid lipase deficiency in the children can show steatotic pattern. Other than there is a huge list of genetic diseases which can cause that pattern. So the last question, liver biopsy in a 5-year non-obese child with hepatomegaly. So which should be the first differential diagnosis? See, you have got a steatotic pattern. So non-alcoholic fatty liver disease, drug-induced, autoimmune hepatitis, or metabolic liver disease inherited.
The majority is answering option D, inherited metabolic liver disease.
Yeah. So that's the correct option. So see, in that age group, once you see steatosis or cholestasis or a combination of these, you should always suspect this inherited diseases. So in children, yes, the list of diagnoses will completely differ. So this is a nice diagnostic approach which I have taken from this article. So see, once you suspect a steatotic disease, so you do have, so other than, see, I did not go into the clinical details and the investigations. So because that's very lengthy topic. So yes, there is a lot of workup for the liver diseases. The important which you need to know is, see, this non-invasive. So CAP is the assessment of the fat which is done by the fibroscan machine. So it's a ultrasound kind of thing. So you can measure the fat, and then the values will be given in decibel. That's the cap. That's the fat values, and then the liver stiffness measurement. So that is the fibrosis. Okay, so this fibrosis is given in kilopascals. So again, these two, they are commonly used for every patient of non-neoplastic disease. And then you have the routine imaging also. But this has actually revolutionized the liver biopsy, this fibroscan. So because this non-invasive uh, assessment is available and that is widely used, so now there are cutoffs available for every other disease, and you can actually guess the amount of the fat and amount of the fibrosis. So then the alcohol history is very important. So if patient has alcohol history, so you will consider alcoholic liver disease or a combination. If he says that no, so there is no such history, then you evaluate for metabolic syndrome. So that will become NAFLD if you get these metabolic risk factors. So you can do a lipid profile and then glycosylated hemoglobin, thyroid function test, and then again the fibroscan for the metabolic syndrome. Then if you don't have this also, then yes, liver biopsy becomes more important if you don't have the classical ALD or the non-alcoholic. Then drug is nowadays a common factor which has to be taken with the history. Then the viral induced, and then these inherited like Wilson's, alpha-1 antitrypsin, and then these are the different disorders which are associated with some defect in the lipid metabolism. So this is one of the group. Once you exclude all the common, so you are going to go towards these uncommon groups. And then the small intestinal diseases. Then if we see the children, so if it is less than 5, then try to look for the history of consanguinity, the family history, sibling history, the syndromic features. That means a detailed systemic examination to look for other stigmata in other organ systems. If the age is greater than 5 and the metabolic risk factors are found, then yes, the MAFLD will become a more common differential for the children. So to conclude, so once you see steatosis, so you see what is the type, what is the percentage, and how it is distributed. So whether it is predominantly steatotic or it is just a component in that disease. Then associated features, cholestasis, inflammation, duct damage, granulomas, every other feature has to be seen. Then the pattern of the fibrosis, whether it is going with the fat and the amount of the fibrosis. In adults, a complete metabolic workup, which includes the body mass index, lipid profile, glycosylated hemoglobin, then the viral serology, the autoimmune serology. So autoimmune includes the ANA, asthma, LKM, at least that has to be there, and a IgG. Then the alcohol and the drug by the history. Then the fibroscan, a very good modality. And then in the children, the consanguinity, the sibling history, and the detailed systemic examination to rule out the inherited diseases. So that's all from my side. So I would call Dr. Rahul for his comments.
Hi. That was a very exhaustive and nice presentation, Dr. Yadav. Very, very impressive. You actually covered most of my gastroenterology, liver part of it. You've already covered the investigations. You've covered whatever I would talk about. So I think two things I would like to say. One is that when do you really, when do we really biopsy fatty liver? It's a big question. So if we have a lot of patients, as you said, pediatric adults who have abnormal liver function tests. So we cannot biopsy everybody, not because of the cost reason, but it's an invasive test. So fibroscan does help us to say there's a fat in the liver, there's fibrosis. But when do you think that a fatty liver patient would benefit from a biopsy? What would you say you can add to us, to our clinical judgment?
Yeah. So actually, the indications of the biopsy. Actually, the spectrum does vary center to center for multiple reasons. So other than the indications for which it is essentially required, yes, because of the different trials going on in the centers and the referral bias, you will have different set of the patients. So everybody should actually identify at their center that what all patients we are getting. So like we have a full-fledged adult gastroenterology department, and we have a we still get lots of liver biopsies, though they have gone down as such if you see the private centers. And then we have a pediatric hepatologist, so the pediatric has gone up in our center. So most of the pediatric liver disease patients have a biopsy. And actually, as we are looking at more and more, so we are finding that sometimes, many times actually, we encounter the findings which are exactly not matching with the clinical. So
True.
as a pathologist, so I will say that yes, unless the patient is sick, so yes, the prerequisites have to be seen. And nowadays, like, newer techniques are also available. So earlier we were getting just the core liver biopsies. So in the sick patients, we get TJLBs, and we do get US guided liver biopsies also nowadays. So
Yeah.
we have got like newer and newer modalities, and they are becoming thinner and smaller and more fragmented and tiny. But I
Okay.
think they are going to have their yes, many times we are getting something which is totally unpredictable as from the clinical point of view. So
Yeah.
yes, the fibroscan is very good. The non-invasive investigations are very good. So for the classic cases, that can be skipped. But nowadays, actually, we are getting mostly like dual pathologies, lot of biopsy from rheumatology, dermatology, neurology. So actually, so that kind of
Great.
dual etiologies.
Yeah. So I reserve my biopsies for mainly, as you said, subacute liver failure, acute liver failure, where I want some urgent answers. I would do a transjugular biopsy and get some answers. That's my prime reason for biopsy. For fatty liver per se, I rarely ever biopsy, I'll be honest with you. And it's only if I'm stuck up with some, very high SGOT-PT, something unusual, then I would biopsy. But my biggest trick in clinical medicine is to take a good history, I think. And you mentioned that before many times. Drugs, 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 drugs. People take herbs, vitamins, giloy to every kind of stuff in the world you can ever think about. In Indian patients take everything. So if you can just take a very good history, you will get some answers, I feel.
Yeah, so drug-induced liver injury is a masquerader, and it can have any pattern. So that's the problem. And in India, when once you will ask the patient, so they'll say they took something, and they don't have any, like, no paper, nothing. They will take something, some ground thing in the paper, and
Yes, yes, yes.
it's the yeah.
It's amazing. Amazing what you can find when you take a good history. You need to get your junior doctor to sit with the patient and go through the entire year of what they've taken. It works. Okay. Thank you very much.
Dr. Rajni, there are two questions, actually, just two questions
Yeah, ma'am.
from that. One is, one person wanted you just repeat explain hepatic necrosis and fibrosis, how to differentiate it with special stains. Like
Okay.
you had explained it, you can just
Yeah.
repeat it.
So necrosis and fibrosis, if want to differentiate, so reticulin stain will not help because there will be condensation in both. So what will help is a Mason's trichrome. So the fibrosis will be dark blue, whereas the necrosis or the collapse will be just faint blue. And then another stain is Orcine. So Orcine actually highlights the elastic fibers. So in the collapse, so they will go off. So the Orcine stain and the empty stain does help to differentiate.
And the next question is, can you just please repeat type 1 and type 2 nuclear glycogenization?
Okay, so the type 1 glycogenized nuclei, they have a membrane which is surrounding that inclusion. So it's covered with a basophilic membrane, whereas the type 2, they don't have a membrane around that inclusion. And type 1 is prognostically more bad. So because that has been found to contain all these autophagy associated proteins and the degenerated organelles. So if they increase more in the number, so that has been implicated as a progressing disease.
Thank you, Dr. Rajni. And one small, Doctor,
Yeah.
can we use, if there is a difference in saying ballooning degeneration and hepatocyte ballooning, like, does it imply two different things or can we use it interchangeably?
Ballooning degeneration?
And like, is ballooning degeneration attributing to acute hepatitis and hepatocyte ballooning for alcoholic liver disease,
So
or
it is the same. So ballooning is a swelling of the hepatocyte and the degeneration and the clearing of that and losing of the contour. So that may be seen in several diseases. So all the features we have actually seen here, they may be seen in other diseases also. So that's why all the features have to be added and put up in the exact proper in conjunction with the clinical scenario and the investigations, then only we can reach a diagnosis. So none of the feature is absolutely specific for any particular disease.
okay. Thank you, Dr. Rajni. Thank you. Any final comments from Dr. Rajni, Dr. Rahul? Like, do you want to say something?
I think maybe I saw some 1-2 questions more.
There have been compliments like and responses other than the doubts.
No more comments from my side. So I don't think. Do we have more questions?
These are
Some
the two
things.
questions. These are two questions which came up actually.
Okay. Okay. So
Thank you.
I would like to thank Dr. Sumit and his team and Dr. Leena and Dr. Rahul. So everybody was actually very cooperative and friendly, and it was nice actually to have this teaching opportunity. So that's a great learning for us also. And all of the delegates and the attendees, if you have any questions with you, so you can actually communicate with me, so you can mail me. So and whenever you visit Delhi, so anyone can drop to our place, so I will be happy to show you around. So you are most welcome to our place.